Yep. Welcome everyone. This is Syed Ahmed from Tech Invention. I also represent this organization called Emerging Biopharmaceutical Manufacturers Network, and very happy to moderate this session. This very interesting session is being brought to you by EBPMN in association with the Health Diplomacy Alliance in Geneva. Before I start and get into the details, I would like to just say a few words about EBPMN. The Emerging Biopharma Manufacturers Network is a not-for-profit organization having members from Latin America, Asia, and Africa. Its secretariat is based out of Butantan in Brazil, and we manage the registered office out here in India, while the treasury is from Sinopharm in China. Our members are increasing year on year, and we're going from strength to strength with one mission of enabling local manufacture of biosimilars and novel biologics across the global south, primarily focused on low middle-income countries. Before I introduce the speakers, what I can tell you is we have a very formidable lineup of speakers, an economist, a researcher, and an AMR survivor whom I will be explaining or rather giving you an overview of their profiles very soon. But would like to hand over the floor to Ms. Katherine Uríbeaz, who is also the founder and executive director of Health Diplomacy Alliance. A few words about Ms. Katherine. Ms. Katherine is a global leader in integrating health into foreign policy and shaping access to healthcare through international cooperation. A former diplomat for the Dominican Republic, she represented her country at the WTO, UN Geneva, and more. Driving impactful health and trade policies, she also leads the diplomatic task force advancing global access to essential medicines. With her deep expertise in international trade and policy development, Ms. Uríbeaz continues to be a powerful advocate for equitable healthcare access worldwide. Over to you, Ms. Katherine, for a brief overview of Health Diplomacy Alliance that you lead.
Thank you very much. Thank you for the introduction and for presenting me. It is a pleasure for us, for the Health Diplomacy Alliance, to co-organize this event with the EBPMN. And I will tell you a little bit about our alliance. Our alliance is a nonprofit organization that is based in Geneva. As it was mentioned, is an organization whose main focus is to work on policy and advocacy, keeping health at the center of foreign policy. Our organization, which has staff in most of the regions, including in India itself, unites not only former diplomats, but also international experts and experts in public health, working on three core focus areas. The first main area, and I think that's why we are here in this event, is One Health, and within One Health, there is quite a strong focus on antimicrobial resistance. Our second focus areas is environmental and climate change intersection with health. And our third focus is sustainable finance of health system. So our mission is to foster global collaboration and enhance stability, and also to promote economic prosperity and integrating health into the international agenda from a bottom-up health diplomacy perspective. So it will be a pleasure to be co-hosting this event and to present further the discussion, what the health diplomacy has been doing in this area. Thank you very much.
Yeah, thanks, Ms. Katherine. Some commendable work and interesting work being done by you at the Health Diplomacy Alliance. And we also look forward to welcoming you back here in India towards the end of April for the World Health Summit, where you have a session. Yeah, I can see that meanwhile, we have participants who have joined in from Latin America, Claudio and team, which is very early out there. Appreciate your participation. We have participants from Africa, Genevieve and team, also from Asia, China. So it's across time zones. Thank you for joining. And what I can promise you is some very interesting insights into the context and concept of AMR. Our AMR does not need any introduction. for all of us in the healthcare domain. It is called as the silent pandemic. And the fact remains that if it goes unchecked, what was attributed to about 1+ million deaths directly to AMR in 2019 is likely to become the most formidable cause of mortality by 2050, with a tenfold increase, almost 10 million deaths. With that said, building on the momentum of 2016 UN high-level meeting and the recently adopted political declaration on AMR, we've seen a growing commitment from nations to act on the global threat of AMR. While the Global Action Plan and various national action plans provided a structured foundation, critical gaps remain, particularly in technical expertise, financial resources, regulatory frameworks, and infrastructure. These challenges continue to hinder our ability to meet key targets in the fight against AMR. Today's webinar brings together leading voices to explore how scientific advances, particularly in the development of innovative solutions, can be paired with political will and health diplomacy to drive equitable access to AMR countermeasures. We are especially honored to have here amongst our speakers, in addition to Ms. Katherine, Professor Urmi Bajpai and Ms. Bhakti Chavan. To give you a brief overview, for those working on or in the field of AMR, Dr. Urmi needs no introduction. But yes, I need to follow the protocol, so a few sentences about her. She's a leading microbiologist and educator with over 25 years of experience, a professor at ANDC University of Delhi and co-founder of the International Bacteriophage Research Consortium. Professor Bajpai's research focuses on innovative therapies for tuberculosis using bacteriophages and other multi-target approaches to combat AMR. As Vice President of the Society of Bacteriophage Research and Therapy, she is a strong advocate for phage therapy and has been widely recognized for her contributions. Through her leadership in both research and education, she has become a leading voice in advancing phage therapy as a powerful solution to AMR. Thanks for joining in, Dr. Urmi. I know it's a Friday evening back here in India and could be an extended one given that Monday is likely to be Eid. I appreciate that you're taking time out of a hectic schedule in your institution to join us. The next speaker is Ms. Bhakti Chavan. She's a dedicated clinical research professional and a passionate advocate for global health. She currently serves as Assistant Manager Clinical Trials at Tech Invention, where she brings in over 5 years of experience in conducting clinical trials. She holds a master's degree in biotechnology and a postgrad diploma in clinical trials. Her journey is deeply personal and inspiring. In 2017, Bhakti was diagnosed with extensive drug-resistant tuberculosis. After 2 years of rigorous treatment, she turned her experience into a mission advocating for those affected by drug-resistant TB. Today, she is an active member of the WHO task force of AMR survivors, using her voice and professional background to raise awareness about AMR. With that, I would like to leave the floor to Dr. Urmi Bajpai, our first speaker, to take us through her perspective of AMR and the context of the phage therapy, which is becoming more acceptable and institutionalized all across. Over to you, Dr. Urmi.
Thank you. Thank you so much, Mr. Syed, for such a nice introduction. I'm really flattered, and I thank the organizers and also happy to be sharing this dais with Ms. Katherine and Ms. Bhakti. So as you mentioned that I'll be talking about AMR, as you said, does not need too much of background, but still I like to, so my talk is basically not too much on the work that I'm doing. It's about why phage therapy is important in today's time because of AMR, and what is being done and what is needed. So that's what I'm trying to communicate to the audience today. And so I'll just like to share my slides now. And please let me know if you can see my slides. I think
Yes, doctor. It's all set.
Just a minute. Yeah, thank you again. And so the title of my topic is phage therapy, potential in mitigating AMR. So if we define AMR, basically means when microorganisms become resistant to any microorganism becoming resistant to any drug. And when when bacteria becomes resistant to antibiotics, then we call it bacterial. And the consequences are devastating, to say the least. You have untreatable infections, increased mortality, longer hospital stays, economic burden, so on and so forth. And it is also a threat to the Sustainable Development Goals. And 10 years ago, around the same time, WHO had committed to a global action plan, which Mr. Syed mentioned. And now about more than 175 countries have developed their own national action plans, which are aligning with the global action plan. So a lot is happening. However, the antimicrobial drug development pipelines are not that well fed. They are like drying, in fact. So what are the important factors we need to understand when we want to mitigate AMR? And that would include estimating not just global, but also regional burdens, because we know there is a skewed burden of AMR. It's not uniform across. And then how is the access to effective antibiotic? Is it uniform again, or is it like in low resource countries, in low and middle income countries? Do we have limited access to antibiotics that are effective? And also that we have to understand that AMR typically we talk about in context of humans, but then AMR is not limited to human health. So what are the catalyzing events in today's time which we consider are promoting these cases of AMR, and which is because of animal farming? As you can see on top right, when you have animal farming of that scale and volume, then there is a excess use of antibiotics, which inadvertently lead to antibiotic resistance. And there is rapid human expansion, a lot of urbanization, deforestation, which is bringing humans in contact with bacteria more often, and the current conflicted war zones also. All of these are like contributing to AMR crisis. And the recent Graham report, which is like the September 24, has predicted. Earlier, we used to hear the stats from that there will be 10 million deaths per year by 2050. But now, between 25 and 2050, there could be about 30 million deaths if timely policy interventions are taken. So these are glaring statistics. Sad to say that on Friday evening, but that's how it is. But then we don't need to be absolutely despondent. We always have to talk of solutions. So I think, to me, foremost solution which you're doing right now is creating awareness and education, because I think people don't understand the gravity, the scale of this problem. So we need continuous awareness and campaigns and other educational programs. Also to highlight now non-pharmaceutical interventions. We saw during COVID that how hand hygiene and distancing, etc., could have averted a lot of infections, and that is what has to be central. When we talk of high tech science, they remain basics. Also, to emphasize on One Health and antibiotic stewardship. Antibiotic stewardship means responsible use of antimicrobials. And I say antibiotic, but any antimicrobial for that matter. Health diplomacy, we'll learn more about from Ms. Katherine. And now, of course, alongside, we need new drugs. We need to feed the drug pipelines. And in those drug pipelines, we just don't need to rely on conventional antibiotics, which we know very well, but also to look at alternatives. And before we talk about alternatives, a brief overview on One Health approach. So we are hearing a lot about it, very rightly so. But this is not a new concept. It's an age-old concept where you emphasize on interconnectedness of humans and animals and the environment. And here we learn that the spread of resistant bacteria also can happen because of this interconnectedness. So this is an age-old concept across civilizations, and now its importance is being understood in several contexts. Today we are talking about AMR. We also know that, and because of that, we know that it's not that antibiotics are consumed only by humans, but there's an excess use of antibiotics in farms, which also contributes to AMR in humans. And because keeping this in mind, there's a quadripartite technical group which is constituted to coordinate integrated surveillance of antimicrobial use and resistance across sectors. So now when I said that what are the alternatives to antibiotics, and as we know that pharmaceutical companies are not that interested in developing new antibiotics, so can we look at something which has been there with us for about 100 years, which were recognized as antibacterials, but kind of forgotten? And these are known as bacteriophages. So to uninitiated, bacteriophages are viruses that specifically they're found in nature, and these are very specific in infecting and killing bacteria. So, in nature has perhaps developed them to keep bacterial population in check. And can we use these phages as therapeutics? Are considered as the most numerous biological entity on Earth and estimated to be about 10 to 31, which is like million times the stars on the sky. What are the distinctive attributes which make bacteriophages so attractive as candidates for antibacterial candidates? One is they're very specific to their hosts. Unlike even the narrow spectrum bacteria are still broad spectrum, whereas bacteriophages are highly specific to their target bacteria. And that helps us saving from their non-target effect on commensals. And we are increasingly understanding the importance of microbiome in the health. And second is that unlike antibiotics, they amplify their number when they infect their host. So their dosing is very different from antibiotics, but they have very good, several studies have shown that there can be a very good potential synergy with antibiotics. And that's why we think that if we use phages, we don't have to abandon antibiotics, but they can be used in conjunction with antibiotics. So a bit of history about phage therapy. So they were first observed by a British physician, as you can see here in the picture, Ernst Hankin. He was commissioned in Agra. And at that time, there was a cholera outbreak, and he observed some antibacterial property in the rivers of Ganga and Yamuna. But at that time, there was not much more information on this, so he reported and kind of forgot about it. But later on, by Frederick Todt and Felix de Herelle, they independently discovered phages, and Felix de Herelle was the one to use phages as therapeutics to treat bacterial infection. So by definition, phage therapy would be therapeutic use of phages for the treatment of bacterial infections. And this therapy can either be personalized or non-personalized, which we'll see a little later. This is practiced till date. They were discovered in early 1920s, as you can see, but then it's been still practiced 100 years after in East European countries like Georgia, Russia, Poland, and some part of France also. But now there's a resurgence in interest because of the failing of antibiotics. So now I'd just like to briefly take you, having given you the background that why this AMR is so grave and we need alternatives. So I'll just briefly tell you what we do in my lab. So we do phage discovery, and for phage discovery, what you need is basically to start with, you need samples from where you can isolate phages. So we, through our travels, we collect samples from across India, and those samples could be environmental, clinical, for wastewater, etc. And so far we have been screening these phages against focus of phages in my lab are mycobacterium, but now we are doing on E. coli and other gram-negative bacteria also. So we screen samples. You can see about 800 have been sampled, and we have about a collection of 300 phages. So we have developed a standard operating protocol for isolation and screening. So we collect samples, and then there are methods. We use a combination of methods, which we call as enrichment method, microtiter-based assay method, spot assay, etc. And these methods are used for getting phage plaques, as you can see here. These are like the bacteria plaques against the bacterial background. These are the transmission electron microscopic images of bacteriophages that we isolate. So over a period of time, we are collecting phages, and these are the various, as I showed you, 300. Once we have phages, then what we do is we characterize them, because the last thing is to identify and find against clinical isolates or whatever target pathogens we identify for our studies. Those which give effective activity, then those we characterize, which includes, I would like to focus mainly here on two parts, which one is genomic characterization, and the other is the activity of phages against biofilm. As you know, biofilms also contribute immensely to drug resistance. So we screen our phages, which are good antibiotic, good biofilm inhibitors or disruptors. Genomic characterization helps us identify that these phages, do they have genes for antibiotic resistance? Do they have genes for virulence? Do they have genes for lysogeny? And if they have, then either we don't use them or we identify them for engineering. Now, when we genomically characterize phages, we find that there are genes in the life cycle of bacteriophages. They also make some enzymes which also damage the bacterial cell wall. As you can see here, this is a schematic drawing of a mycobacterial cell wall. And what we can see here is that this is a peptidoglycan and this is the mycolyl arabinogalactan. Little technical, but just bear me. So what I'm showing you here is Pac-Man cartoons. And these are the site of action which these enzymes act upon and damage the cell wall. So can we use these phage enzymes as antibiotics? So they're like protein antibiotics. And so you can actually purify them as recombinant proteins after genomic annotation and identifying the genes. And then we can test them as we do antibiotics. So the way we do antibiotic susceptibility tests, likewise, you can do susceptibility tests for endolysins. And here I want to show that even when we do antibiotic enzyme synergy, then what I want to show here is this is from my collaborators who are working on MTB using lysins derived from mycobacteriophages, that you can see a shift in the MIC if you use a synergy of lysin B and antibiotics. So that tells us that these antibiotic, the lysins, and similar results we find with phages also, which tell that if you use in either an additive effect or synergistic effect, you can perhaps make bacteria resensitized to antibiotic, which will be, I think, a great contribution of phages if we don't, and because that's how we use them typically in combination with phages. To summarize, what I want to tell you is what are the key highlights which make them so popular nowadays, and I see the critical number of researchers working on phages has actually exponentially increased. So their key advantages are that phages or phage enzymes can kill drug-resistant bacteria, pathogens, and they can also inhibit and disrupt biofilms. They act with high precision, so they don't cause any collateral damage as broad-spectrum antibiotics do. And hence they're very safe for commensal and symbiotic flora. And their synergy with associated antibiotics make antibiotics useful again, and that's something which is very promising. And phages, bacteria do develop resistance against phages, but endolysins so far, this is a relatively new area, about 25 years, but there are no known resistance reported against endolysins. So that's the key point. However, of course, when we are dealing with this, and it's not yet a mainstream, in fact, we are in the early stages of the comeback part of phage therapy. So what are the challenges which researchers and clinicians think, what are the gaps in our understanding when we want to use phages or enzymes? So one is the pharmacokinetics, because phages, when they infect their host, they multiply and their number increases. And because of that, their pharmacokinetics and dynamics are not same as a dose which is fixed dose, like we give antibiotic. Second is the immune response. Like, this is a concern I find whether I give a webinar amongst students or to my grant reviewers. This response keeps coming back, though it's not that much a major concern by the people who have been practicing phage therapy for decades, but still this is considered to be one of the key challenge, and that's something needs to be addressed by anybody who wants to take develop phages as therapeutics. Also the stability, because they are biological entity, they have their own DNA and protein. So how stable they are over a period of time, and the complexity of scaling up, especially if you want to, do a decentralized centralized production of phages. So the scaling up can be a challenge. Also, there has been found that same phage preparation gives variable response in patients. So how to understand what is the driving factor? And then, of course, the debate about phage production, that how should they be produced? Should they be a GMP practice, good manufacturing practice, or can they be a magistral preparation, which is safe and efficacious enough? And so to conclude, if I may just summarize, what points do I think of when we want to propose and bring phages into practice as therapeutics? The major thing is AMR is a global issue. It's a pandemic. It needs to be accepted. Second is that phages and endolysins are among the best alternatives that we have. But what is needed is concerted efforts to streamline the scattered effect. I see there are a lot of research going on, but then is there an end-to-end research going on, and how many? That we need to think of. And so we need to bring academia, medicine, industry collaboration for sure. I'll just not pick up all the points, what are more important for today's talk. We need to bring in high throughput technologies to leverage the abundance of phages that are there in nature. We need to bring more of machine learning and AI. We need to characterize phages. 100 years ago, we couldn't have characterized them so well. But now, if you want to have a reproducible and a QC required product development, that phages need to be characterized thoroughly. And we have the wherewithal to do that. we need to build phage banks against, to begin with, maybe against priority pathogens, and because we need to have diversity also in phages, not just that phages are there, but they need to be different from each other. And we need to have more innovative models for clinical trials, because that's the bottleneck, because that's the most expensive part. And so how can we, do clinical trials, because every phage preparation cannot undergo clinical trials. So we need a lot of advocacy for phage therapy from non-phage people, because we tend to be in an echo chamber where we say, yes, we are very good, we're doing a great job. But once we have the advocacy and the policy, then they can perhaps think of that what is missing to bring phages, which are which have given impressive results, but then somehow there is not enough science policy around this, and also the regulatory frameworks and the legislative framework around phages is not very clear, and because of which, even if people have phage collections, but they can't be used for therapy purpose. And the last point I want to make is that there should be some benchmarking. When we compare phages and we want to use them as antibacterials, yes, but we can't compare them entirely as antibiotics, because they're very different from each other. One is a biological entity, one is chemical. So we have to see what kind of benchmarking is required when we want to develop and use phages as drugs. So that's something I want the policymakers to dwell on. So, and in the end, I want to say that there's a lot of scope for phage research in education and innovation. We need to bring scientific curiosity. We need to bring in multidisciplinary collaboration. We need to engage right from early stages of academia, because that's where we can, a large part of phage therapy can be done. The early stages can be done in academia very well. And to do this kind of promotion and create awareness, like as Mr. Syed said, I co-founded this International Bacteriophage Research Consortium in 2018 or 18. And since then, we have been, arranging a lot of webinars by experts. And I see that in these years, a lot more interest has been generated about phages, and I see funds being also given, and many non-phage people are joining the bandwagon, writing grants, getting also. This is about Bacteriophage Society in India, which is this is the current office bearers and executive council members. So our thrust is to make phage therapy happen in India. And here on the left is the president, Mr. Dr. Gopal Nath, who has practiced and delivered phage therapy in about 200 cases. Rest of us, this is me, I'm the vice president. Taruna is maintaining a phage bank. Dr. Taruna is maintaining a phage bank. And all of us have come together to spearhead and accelerate the phage movement, so to say, in India, and make it happen. With that, I thank you, and I thank you once again for your attention and the opportunity.
Thanks a lot, Dr. Urmi. I think very well covered in a very short span of time. Very, very insightful, like always. Yes, there are a couple of questions that come to my mind, and there are a couple of questions in the chat box, but I believe we can have those questions towards the end of the session. I think the good part is phage therapy is getting more and more noticed, so also interest in endolysines. And the fact that you're looking at it not just as an alternative, but a concomitant therapy, which can go hand in hand with antibiotics, that makes it more powerful going forward. With that, let me hand over the floor to Ms. Katherine for her thoughts on the perspective of AMR from a policy perspective. Over to you, Ms. Katherine.
Thank you very much. I think Dr. Bahai has really set up the scenario for the discussion. And as I say, why health diplomacy comes into place in the equation of the discussion of what is happening in not only in the policies on the policy side, but also with the scientific evidence of it. So I'll give a little bit, I will present briefly of what we are doing at the Health Diplomacy Alliance and why it's such an important issue in our line of work. I hope you can see my screen. So as you mentioned, antimicrobial resistance is not just a health issue. It is a global economic and security challenge that we all face, that all countries face, and require a strong health diplomacy to bring together not only international institutions, but governments and other stakeholders. And you mentioned it quite good, the importance of having research, the importance of having academia, the importance to having survivors and all the stakeholders that are involved in this equation, as we call it. As I mentioned, for the Health Diplomacy Alliance, it's quite important having an approach from the One Health perspective. Is even embedded in our bylaws. Why? Because it emphasizes the inclusivity and the equity in terms of finding equitable solutions. Why? Because AMR is a global crisis, and it will not affect only one country. It will affect all of us at a different phase. And why we should look at AMR from the One Health perspective? Because we have to understand that there is not only the antibiotics AMR kind of a spectrum work, but also how that impacts into the environment and how that impacts into zoonotic disease. So if we look at the health diplomacy aspect and response, we understand that there is a challenge, and it was mentioned. Now we have a quadripartite organization that are working on that, the FAO, the World Health Organization of Animal Health, the UNEP, which is the environmental, and the WHO, who are working quite tireless in all the process to bring aspect to challenge those divides in terms of policy, the fragmentations that we see quite often in terms of policy, and also the differentiation of national priorities and sometimes the lack of enforcement mechanism, even though it's not the role of the quadripartite, but to provide technical support for countries and also to align those efforts that are happening at the global level. I'm going to dive a little bit more into the details of what the quadripartite has been doing, especially after new political commitments that had happened in the last years, and why it's so important having health diplomacy as a mean to convey this kind of work. There is a lot of work, as it was mentioned, in terms of the global action plan that has been put forward, and this global action plan has to be renewed in the coming months for 2026. Some countries, they have already implemented or have in place some national plan of actions. Some they do not, but some they need to reinforce it, and that's why you need the right evidence and the right appropriate policy to be implemented. Here, health diplomacy comes as a convener, as a bridge in terms of what it is need to do between science and policy. There is a need to have convening stakeholders to drive this political engagement. We have seen it in the last, I would say, in the last 10 years, quite attention in terms of the concept of One Health. That is a really old concept that has been used mostly in the veterinary world, but is more widely being used right now in terms of implementation and as an approach of implementations of programs at the national levels. The need to a strong global governance in terms of One Health and antimicrobial resistance, and the multilateral cooperation. And if we look at the multilateral cooperation, it is really important to see the aspect in terms of the strategy and the cooperations that low-middle income countries are doing and the work at the regional level. So low-middle income countries, as it was said, faces quite different constraints in terms of priorities and financial constraints in terms for implementing policies that are adaptable to their tackling of AMR. There is many complexities, but if we have a good coordinated regional cooperation and mechanism, we can have improve in terms of drug regulations disparities, in data sharing that it was already mentioned in one of the things that we need in the most in terms of tackling antimicrobial resistance. There is an aspect in terms of pool procurement mechanism for joint surveillance network, and there comes the importance of investment in research and innovation that it was mentioned. And that is where health diplomacy comes into place, into bridging these kind of gaps that we're seeing, not only at the national level, but at the regional level by all the regional movements that is happening right now, and also at the global level, and the need to harmonize regional policy and cross-border surveillance and coordination. Another aspect that is important to have in consideration is the joint financing initiatives. So there are many initiatives that are happening at the regional and at the global level, but it requires that it tackles the limited resources and the aspects to harmonize policies to make it effective. As I mentioned, there are many actions happening at the global level. There are many organizations that are working on bridging this gap and bringing health diplomacy into place. And we're quite happy to join some of these organizations that are happening and that are working at the global level. We have now had many initiatives in terms of actions like the One Health high-level panel. There's One Health initiative. There is the group of leaders on antimicrobial resistance who has bring in the last years a lot of attention at the political level of AMR as a growing crisis. And there is a lot of, you will hear a little bit more on the WHO task survivors, but we also have working groups on youth and any other other aspects. And as well, the quasi-partner organizations have created the multi-stakeholder partnership platform, which has an amazing work in terms of mobilizing civil societies that are working not only at the national level, but at the global level. So one of the things that we see, and before going into more of the political aspect of what has been happening in the last year, we understand that there is several AMR governance strategies that are required. So there is a need in terms of stewardship, AMR stewardship, that it needs to be reinforced at the regional level and at the national level. There is also the need to continue the accountability mechanism to track where are the aspects that are failing and how that it should be integrated at the national level, especially when it comes to coordination of mechanism, One Health approach, as we see it in terms of discussion at the national level. But if we look and in terms of what has been in the last years, and there's been a lot of work that not only academia has been doing, but the industry, research institutes, civil society, in order to call the attention of this growing crisis. And from the Health Diplomacy Alliance, we see a departing line or a wake-up call from the last commitment that member states had taken in consideration by the commitments during the United Nations high-level meeting on AMR. There is somehow ambitions in terms of how we want to reduce the burden of antimicrobial resistance, and also the investment that is required for it. In comparisons with other kind of initiatives is not much, but we are in a really difficult geopolitical scenarios that require a lot of collaborations, and that means public-public partnership in order to tackle AMR. And the way we see it is that right now we are at a crossroad in terms of what it needs to be done and what we can achieve, tackling not only what we have committed in September, what we have done in the past, but as well what we would like to be accomplishing and how we are accountable to it. Just as a little bit of overview, only in the last year we have had many aspects that has called political attention in terms of bringing better design of policies and engaging even policymakers into the discussions at all levels, including with academia, scientific, and the private sector. And as you know, we are currently in the process of negotiation of a pandemic agreement that is to be adopted in May, which has a strong focus on One Health approach. There has been several discussions in the African region in terms of One Health Sustainable Forum that it was celebrated in Dakar, and also, as I mentioned, the start line to refresh and to put a line of the work that we're doing in terms of the high-level meeting that happened in New York, as well as some commitments of the JETA commitment that it was celebrated last year in Saudi Arabia. So how we see this priority from the Health Diplomacy Alliance? We now have, which is quite good for this year, the quadripartite has established a roadmap in terms of the establishment of the independent panel of evidence for action on AMR. And why this is so important? Because we need the science evidence to advance in what are the aspects that we are requiring in terms of tackling antimicrobial resistance. And this panel, it not only requires to be an independent panel, but from the Health Diplomacy Alliance perspective, we understand that it should not be a panel that it should be policy prescriptive. Why? Because each policy implementation, each policy design at the regional and national level should be adapted to the scientific evidence and the current national context of each country. We are continuing in terms of advocating with member states in to continue not only the work of or bringing high political attention, but also to the accountability, as we call it, the accountability checkpoints, to continue monitoring what is happening, how governments are working with the private sector, how private sector is supporting governments, and how investment is put forward in terms of research and education and awareness. So it's fundamental that we use health diplomacy as a means to convey this public-private partnership to accelerate not only affordable access to antimicrobial countermeasures, but also to invest in what is required in terms of research on new technologies and also the mobilization and awareness of the work. As I finalize, and I will definitely go more into the details if some other questions come into forward. We are happy to be part of this webinar as a warm-up of a continued discussions that we're going to be having in the coming weeks in New Delhi as part of the discussion in terms of how we see AMR process at the regional level for Asia and Asia Pacific. And we will be during the World Health Summit that is celebrating in the coming weeks, trying to integrate also how climate change and sustainable finances comes into place into the discussions, in the question of discussions on antimicrobial resistance and the role of India into leadership of this discussion at the regional level. In that same tone, I would also like to say that the conversations continue as we are putting, there's a lot of discussions and geopolitical changes happening right now. So there's also continued discussions on what are the next steps in terms of antimicrobial resistance, with a quite focus on prevention and sustainable finance for antimicrobial resistance. I will stop here, and I will be happy to continue the conversation. But I will also like to emphasize that the way health diplomacy comes into place is not only from health diplomacy from track 1, track 2, but the most important part is track 3, people-to-people diplomacy. And none of the efforts that we do is enough until we are able to effectively implement policies and actions that at the end is translated to those who are affected the most. Thank you very much.
Thanks a lot for that, Dr. Katherine. I think the kind of work that's being done at HDA, steered by you, is very interesting. And of course, we do need a concentrated effort from, especially in the arena of policy and advocacy. We definitely see increased decibel levels all across for AMR awareness, prevention, and so on. And also we foresee a lot of initiatives coming in from organizations like the CARBEX, the AMR Action Fund, a lot more funding options available out there for innovation and so on. So we should also put some of the initiatives from Dr. Urmi on track going forward. Yeah, with that, would like to hand over the floor to Bhakti. Over to you, Bhakti. A special point out here is not many come forward to talk about it. And Bhakti's done that very efficiently and very effectively. Kudos to you, Bhakti. Over to you.
Thank you, Mr. Sayed. I would like to thank EBPMN and HDA for giving me this opportunity to share my story and create more awareness about the AMR. I'm a member of WHO Task Force of AMR survivors. So here, initially, I would like to give you the overview of the task force, and then I would like to share my personal experience of fighting AMR infection. Slides are moving.
Yeah, they are moving.
Yes, but
Yeah, sorry for the glitch. The task force is constituted by the people who have actually survived the AMR infections themselves, or they cared for those who have the have a serious drug resistance infections. So we have total 12 members in this task force from LMICs and as well as the high income countries. This task force established in year 2023. So the aim behind establishing this task force is to give the human face to this AMR problem and moving away from the technical framing. So as we talk about the AMR, there is always a numbers which we talks about the mortality rate or the number of people affected with the AMR, but there is no real stories of people who survive the AMR or the patient voice is missing. So establishing task force aim is to give the human face to this AMR issue. AMR is a problem now. We always state that AMR can be a future pandemic or is a silent pandemic. No, it's a serious issue, and there are many people who have, survived this infection or right now, they are undergoing the treatment for this AMR infections. So it's a problem now. A patient suffers. So advocate for the patient centric and the people centric interventions are very important. There is a huge gap in the diagnosis, access to the novel medicines, and the patients across the LMICs face these issues very critically. Then making this AMR issue visible, raising the visibility of AMR amongst the stakeholders, especially to the policymakers, is the aim of this task force. I'm not able to move my slides. So function of the task force is sharing the AMR survival story through the formal or the social media, engagement in WHO event and discussions on AMR, raising awareness of AMR, advocating for the relevant improvement across the clinical research, development and policies, advocacy for the increased funding and the donor commitment for the AMR response at all levels, and developing frameworks for the patient advocacy and identifying the priorities area. So these are the five main functions which tells you about advocacy, engagement, participation, sharing the stories and inform about the AMR. So I would like to share my personal experience. So facing superbugs or fighting against AMR in 2017, after completing my studies, I was looking for a job when I started observing weight loss. Also a non-painful lymphatic swelling on right side of my neck. So I visited my family physician who prescribed me with the 7 days antibiotic course, but despite of which my swelling was not reducing. So I visited another doctor who asked me to undergo few basic testings like microscopic examination of the by the needle aspiration of this fluid in the lymphatic node, which just tell you that this is a tuberculosis or you are infecting with a non-tuberculosis bacteria. So after those results, he put me on the first line antibiotics drugs. But then I decided to take a second opinion of the chest physician, who asked me to undergo the biopsy test, and he sent the samples for the advanced testing like gene expert and drug sensitivity test. So on the same day when I undergo biopsy, my stitches opened and due to the active infection. And next day, my gene expert report came with the news that I'm suffering with MDR TB. Immediately, my doctor put me on the second line antibiotics drugs. Then after 20 days, my culture report came positive and stating that I am suffering with extensive drug resistant TB, where most of the powerful TB medicines are not working in my case. So my treatment was lasted for 2 years. I took almost 250 to 300 daily painful injections for 8 months. My treatment included 8 different antibiotics, and which also include a novel antibiotics like bedaquiline and delaminate. So here is my report. If you can see, the culture test state that I was resistant to the most powerful TB medications. Among the thousands of patients started the treatment of the XDR TB in 2023 in 26 countries and territories. The outcome of this treatment, 26% people die due to the disease or due to the side effect of this treatments. So how this treatment affected me personally, socially, and financially. These are few photographs I have put to give you the real my experience, how I experienced this 2 years treatment. So I lost almost 8 to 10 kgs of weight, repeated hospitalization due to the side effect of antibiotics, nausea, vomiting kind of side effects I suffered. There are few medications like cycloserine, which put you in the depression, which depression, anxieties. Daily painful injection is another task. Then also I observed the optical neuropathy, due to which my vision got blurred for few weeks. Also, I was on clofamazine medicine, which consists of red colored dye. So when you take those medicine, it changes your skin tone to reddish brown color. If you can see my pictures here, my skin tone is almost reddish brown in color. So due to which I stopped looking into the mirror. If we talk about the social impact, the TB itself comes with a stigma. So you cannot really tell people that you are suffering with TB. So that's another task to having this social anxiety. I have to isolate myself. Again, if we talk about the financial impact, I was fortunate enough to get my treatment funded through the international organization called MSF. But repeated hospitalization cost was there, and due to the career break, there was no earning, and this financial things I have to suffer. Extensive TB patient, if we see, they swallow almost 14,600 pills in 2 years of their treatment, and they have to take daily painful injectables. But as per the new guidelines now, there is no injectables included, and the treatments is also shortened to 9 months now. So thanks to medical advancements. How I overcome this TB, my mantra to overcome this infection, or what worked for me. So timely diagnosis is very important in this AMR or any kind of drug resistance infection. So as you detect the infection at early stage, it will help you to complete the treatment. I got access to the novel medicines. Talking to other TB survivors helps a lot, because sometimes you can't share your thoughts or feelings to your family or friends. But yeah, the people who have actually survived this disease, they are the one who can, encourage you, motivate you to complete your treatment. Family support is play a crucial role. And after my injectable stop, I enrolled for the education course to keep my mind busy. So, without any previous history of tuberculosis, I diagnosed with the extensive drug-resistant TB. So, I believe this drug-resistant strains are already circulating in the environment, and if this can happen to me, this can happen to anybody. So, we need to act now. During my treatment, I started advocating and creating awareness for the AMR. So these are the few platforms where I shared my story to create an awareness. Uh, this is the story I've shared during my treatment in the MSF magazine. I have attended the WHO conference on tuberculosis, where we demanded for the lower cost medicines and lower cost diagnosis availability. And these are the various platforms where I've shared my stories. Here's the one short film is available on YouTube. So I believe patients' stories are important because they are the one who face the disease and they know the gaps in the actual policies. When we say antibiotic stewardship is important or access to the novel medicine is important or the drug sensitivity test is important, but then how many of them are getting diagnosed timely or getting access to those medicine? We need to check that. So facts make people think, but stories make people act. So I think sharing the personal stories of survivors can create a huge difference, and we should involve the patient's voice in policy making. So on the closing remark, I just would like to say that AMR is invisible, but I am not. Thank you.
Yeah, thanks for that, Bhakti. I think yours is a story of real grit, determination, resilience. And I think we need to create more awareness with AMR survivors like you. And I'm glad that you've come forward. The issue is there are many survivors out there who are not coming forward because of various reasons. And I think you have overcome that barrier and you're working closely with the WHO task force and so on. So amazing. More power to you.
Thank you.
Yeah. With that, we have quite a few questions in the chat box, and we are running short of time. So we're just 2 minutes into the cessation of this session, but I think we should take a couple of questions which have come in from the audience in the chat box. The first question is, how can awareness of AMR be spread to the common man? General public is not talking about it, and they must know about the antibiotic overuse, misuse to enable stewardship and ensure use only when needed. What can be done? Would any of the speakers like to take that?
I might jump in if I may, Naveen.
Yes, Dr. Katherine.
Specialize a researcher, but one of the things that is being discussed at the global level is not only having the definition of AMR in a more simple manner and language, but also how we advocate it, or how we inform, how we educate our population, how we engage with patients, how we educate even our industry, how we advocate to have a common language among practitioners to not only use the correct terminology, but also how to inform patients, inform the primary health care workers in that sense, and what is the role of the industry to do so? What is the role of policymakers? So I think there is a lot of work that it needs to be done in terms of advocacy and health diplomacy comes in placing that into bringing that into our perspective.
Yeah, thanks for that, Katherine. There's a question which is, I think, more specific to Dr. Urmi. The question is it possible that the use of bacteriophages leads to a similar situation as AMR in the future? I presume they are referring to resistance to phages and resistance to lysines. So would you like to take that?
Yeah, good question. So quite likely, as in, see, antibiotic stocks are few. We don't have unlimited diversity and number of antibiotics, but phages are diverse, but still I would say we are starting now that every country wants to at least try it. I would say there should be a judicious use for any antimicrobial, and also there should be phage stewardship also. But I don't see that it will be as brave as antibiotic resistance because, as I said, that the base of phages which can be used as therapeutics is much broader. But yes, we need to be judicious in not only using phages when they are right, but also while selecting phages out of the whole big stock. So it's not a very it is likely, and that is why there is already discussion on phage stewardship also, even if it's not mainstream. Even it will be used maybe for a large part as conjunction as an adjunct therapy, but still I would say not as grave, but I don't see it not happening. So we need to be very cautious, very, very much.
A quick one in succession. They are asking about the also how cost effective would phage therapy be? I know it's a little too difficult to answer that, but just a perspective.
So as I mentioned that the phage therapy can be divided into personalized and non-personalized. Now, if it is personalized, then the cost goes up. But if it is non-personalized, which means that there are phage pre-prepared phage cocktails, which is mixture of phages, which are tested against, then the cost comes down. But given that there is no standard one dose preparation, like we have chemical formulation for antibiotics, every phage is different. And so we have to continuously evolve those phages to meet, to see that they we do phage susceptibility tests as we do antibiotic susceptibility tests. So overall, the cost depends upon the scale in which the phages will be used. As of now, it is expensive because you have to have that set up to make phages. But if it grows and there is more coherence in terms of production, scale up, distribution, and use, then I think the cost can come down. But as of now, it's mostly personalized and hence expensive.
Thanks for that. There are many more questions in the chat box, and I'm afraid we have already overshot it by 3 minutes. However, I'll have one question for Bhakti and then quickly wrap up the session. The question is, how can youth and early career professionals be engaged in patient-centered movements like the AMR Survivors Task Force?
Youth and career-oriented researchers play a crucial role, like WHO task force of AMR survivors. We should have this kind of task force at country level, which include people from various domain like researchers, youth, AMR patient voice. So that will help to address the situation at the country level. So researchers can talk about more the current research and how we can advance the current diagnosis, treatment, or the gaps in the research. Youth, maybe they will use the platform of social media and all to share the maximum, to create an awareness about the AMR. So I think we should come together as a society and create the awareness, as well as we need to address this situation very seriously now.
Agreed, agreed. Thanks for that, Bhakti. I'm thankful to the audience from various time zones. Stayed glued to the screen, no drop-offs through the session. So I can imagine how interesting the session must have been for all of you. From very early morning hours in Latin America to the mid-time zones to late evening out here. Thanks for being there. There are more questions which we're not able to take for paucity of time, but we promise we have all these in the chat box and we'll try and mail it out to you because we do have your email IDs and we'll find a way of reaching out to you. With the promise of bringing many more such insightful sessions for the cause of AMR and many such initiatives of impact, would like to thank Dr. Urmi Bajpai, Ms. Katherine Uríbeaz, and Bhakti. I don't think we could have asked for a better combination of some of an expert in policy and advocacy, a scientist working on some exceptional work on novel therapies, and a survivor, which frankly, I couldn't speak after your session. It got me a little emotional too. although we've been working together for the last 5 years. Thanks for that. And on behalf of EBPMN and HDA, thanks for being a part of this session. Look forward to catching up on many more. With that, would like to sign off. Thank you.
Thank you. Thank you so much.